Okay, so today I will try to teach you how to resuscitate a newborn babies and how um, can help a newborn baby. So the objectives is to give you how to anticipate the resuscitation need and how we do a consultation by doctors before and how we approach the baby and what are the intervention and why we fail and when we stop resuscitating and when we hold it, don't do it, and what we do with post resuscitation. And I want to tell you if you think of something called golden hour, and there is something called gentle care. Okay, so you have to know that out of 100, 10 will need some help. One will need intensive help. So intensive help mean invasive ventilation central line or inotropes. So we although need always skilled personnel and we need equipment to take care of these babies. Now, these are some of the equipments that we need to do resuscitations, including suction equipment, intubation requirement, some medication that we use very frequent, and we also need miscellaneous items such as warmers and warm towel and cardiac monitor and pulse oximetry and so on. Now, there are few requirements for very small babies. So like polyethylene bags, and the polyethylene bags are the same bags, the same zipper that we put the sandwich in, or we put the chicken, the frozen chicken in. So you put the baby inside this because it prevents evaporation of water, and therefore it prevents temperature change of the baby and decrease the need for fluid. The preterm babies are very difficult to intubate, so I need somebody who knows how to intubate. And if that body failed, he or she knows why they failed. You need surfactant. You need to take care of the skin. It can be injured very easy. We need very small sized lines. We need hat and we need diapers. Now, we said anticipation of need for resuscitation, and that's from what we call it high-risk deliveries. And high-risk deliveries are varies. We have maternal high-risk deliveries, whether it's a medical obstetrics, so the mother have, for example, twin, the mother has like hypertension, diabetes, have or in the current pregnancy, also in the previous pregnancy, have cesarean section, there is an infection, there is a previous hemorrhage, previous premature, and so on, premature delivery, and so on. And there are fetal conditions, such as small baby or very large baby or RDS or pulmonary hypertension, and so on. Okay, and there is antepartum. There is complication just happen before delivery that can increase obstructive labor, short cord, bleeding, trauma, and these all. Okay, and we have complication happen in the delivery, delay management, hypoglycemia, seizure, all can happen during delivery. Okay, and sometimes the babies are not in high risk, but they get very sick, and that's what we do when we have what we call it neonatal code blue. So instead of shouting help, أحتاج مساعدة or something like that, you just put press a knob, and then there will be like announcement intercom telling everybody who's duty with that baby or taking care of babies to come and help to that point. And that's what we call it neonatal code, and they usually called blue, but some people say other colors. So you can say once you announce inside the hospital neonatal code blue, the patient will not understand, but the staff who's concerned and be part of the team will understand. So that's the benefit when we say code. So for example, white code for bump, yellow code, for example, for violent patient, red code for CPR, and blue code for resuscitation. So these are codes. We say code blue, neonatal code blue, or code blue. So everybody will know that there is a baby need help, but other people who's outside the medical team will not know. And from the high risk you have to decide whether the doctor need to attend or not to attend. Now I know here doctors should attend. But in certain places where you don't have enough doctors, we have to decide whether to attend or not attend, and then only the nurse attend. Okay. Do we understand what is high-risk delivery? Any question?
No.
Okay. Equipment for, again, we've talked about, there is equipment that we need, so I'm going to pass these. Okay. What are the first few things that is related to the preterm baby? First things is hypothermia. And the problem with resuscitation, people concerned about the breathing and intubation, and they forget the hypothermia, and it's more effective or more dangerous on the baby than ventilation. The second problem is we are not able to ventilate, especially when you don't know how to hold the C and E, and you cannot provide effective ventilation. Now, there is ventilation and there is effective ventilation. Ventilation means you ventilate, but effective ventilation means you see chest rise and oxygen. You can also easily damage the organ of premature baby. So we have hypothermia, inadequate ventilation, infection, and organ damage, and hypoglycemia. Very important that the sugar should start for the baby within 10 minutes of life. And I will show you a timetable of how to do. We've talked about it, that we need certain few things for preterm baby. Okay. Now, what are the pillars for good premature care and better survival? First, antenatal steroid. It's very important that the mother receive betamethasone or dexamethasone for babies at risk of premature delivery within certain gestational age. The second important topic is increase room temperature. And that's a big problem in all the hospitals that I work, because the hospitals are not designed to control the temperature. There is central temperature, not peripheral, not controlled by the room. And once you call the maintenance or the bioengineer, it takes time to change the temperature. And the room temperature, where the baby born less than 1,500 grams of birth weight, are very vital for the survival. So the room temperature should be 25. 23 is okay, but 25 is ideal to 27 degrees Celsius. Delay cord clamping, lots of changes have happened. So the ideal is to give more than 1 minute, but the longer the better. Delay cord clamping can decrease anemia, decrease the need for ventilation, decrease many things. And early sugar infusion. The sugar should start and hit the baby at the age of 10 minutes, because after that, the baby cannot maintain the sugar as the baby was taking persistent, continuous infusion of sugar through umbilical cord. Early caffeine can prevent intubation, and early CPAP to achieve a good functional residual capacity. So these are the pillars for having a better premature survivals. Any question here? Okay. Antenatal consult, when we go to the parent and talk to them, first thing we tell them, what is the percentage? Is their baby going to make it? And we'll tell them how long the baby will stay and what are the course of management. And if the baby didn't die, what is the complication, the morbidity? Complication, we can divide it according to the system. And we'll tell them when the baby can go home, and of course the cost, very important, very expensive, and some poor families cannot pay. And I face this problem everywhere I go. So how we resuscitate? When we resuscitate, we ask questions. So remember, we ask questions. Now, what is the gestation? I mean, is the baby term or not? If the baby term does not need resuscitation, if it's a preterm, then he or she will be probably need intubation. If the membrane rupture, is it clear or not clear? Is the baby breathing or crying, or we expect the baby will breathe or cry? Any additional risk factors? Prematurity, mother hypertensive, diabetic, twin, big weight, less weight, and so on. And do we have a plan to manage the cord? How we cut the cord, how we clean the cord, okay? So if the answer is the yes, the baby is term, the fluid is clear, he will be breathing and crying, there is no additional risk factors, and we have a plan for care of the placenta, then we only need to do, we only need what we call it well baby care or routine care or combined care. And that means the baby will be with his mom. Okay, so that a well baby care, a routine care, or a combined care. Combined care means the baby with the mother, so we care both of them combined. Okay, something called people call post neonatal care, or well baby care, or routine care. And the routine care is we do delay cord clamping, we examine the baby within 24 hours, we vaccinate, we circumcise if religiously required, we screen, we do neonatal screening, and we establish breastfeeding. So if the answer is yes to that. If the answer is no, then we need to initiate an RP, neonatal resuscitation program. It's exactly like one we did for the child, but there were a few modifications. So if no, then we initiate an RP. And then we assess the baby to initial step of resuscitation. If the baby responds to initial step of resuscitation, we go to neonatal monitoring care. So remember, first we have well baby care, but if the baby responded to initial step of resuscitation, we go to monitoring care. So again, we do delay cord clamping, we do whatever we did in the routine care, but we add here checking vital signs every 2 to 4 hours. We might need to do gas, sugar, we might need to do sepsis workup and starting antibiotics. Are we clear so far? So 5 questions, yes, routine care, no, initiate NRP, responded, yes, monitoring care. Clear? Questions? Please ask questions if you have any concern, or if you didn't understand, or if you want me to repeat, whatever you. Okay? Now, if the baby did not respond to the first initial step of resuscitation, we go to intensive care. And intensive care means we have lines, inotropes, and invasive ventilation. So this is the algorithm of NRP. And you can see it's composed of block of time. And this time composed of evaluate, identify, intervene. Now, the NRP, there is additions, and last addition is number 8, and there's a few changes with the 8th edition, different from 7th edition. Okay, so the question became gestational age, amniotic fluid, additional risk, and umbilical care plan. In 7th edition, there was gestational age, amniotic fluid clear, how many babies, and additional risk factors. So we removed how many baby and we added in the new edition the umbilical cord management. So that's the difference between NRP 8th edition and 7th edition. In the 7th edition, instead of having range, the medication dose changed to fixed dose. So you can see instead of these ranges, now it's become fixed dose. And in 7th edition, the resuscitation continued to 20 minutes. Previously, we only continued to 10 minutes. So that's another change. And in the 7th edition, whenever alternative airway is needed, cardiorespiratory monitor should be connected. So that's another change. Now, so again, NRP is assessment and action. Assessment in between evaluation and then you act. Evaluate, identify, intervene, and these should be done within 30 seconds. So NRB is helping the baby in a block of time, and this block is 30 seconds, composed of evaluate, identify, intervene. So we also do another evaluation and intervention whenever we do procedure or we do an intervention. Any question so far? Okay, so the baby born, we ask our 4 questions. Is the baby term or not? Is the amniotic fluid clear or not? If there is no additional risk factor, and do we have a plan to care the umbilical cord? So if the answer is yes, we do routine care, which we warm the baby, we maintain the temperature, we position the airway in a sniffing position, we clear secretion if there is any, we dry the baby, and we keep evaluate the baby, we keep the baby with mom, we do delay cord clamping, we establish breastfeeding, we should examine the baby within 24 hours, we might vaccinate and circumcise. Now, if the answer is no to this answer, the initial step of resuscitation is exactly like here, but we add stimulation. So that's the difference between the answer yes and no. So if there is no risk factor, routine care. If there is risk factors, routine care plus stimulation. And remember, it's a block of time of 30 seconds. Question?
Yes, but what do you mean by stimulation?
I will show you.
Come on.
I will show you later. Okay. So who's qualified for routine care when the answer to the questions is the baby term, is amniotic fluid clear, is there is no risk factors, and we have a con. So if the answer is yes, who will baby will go for the routine care is a baby who born at term when amniotic fluid is clear and there is no additional risk factors, such as the tone is good, the baby is crying and breathing, and there is no maternal, no delivery, and no fetal problem. Now, who is qualified for further resuscitation? When the baby is failed to meet the 4 questions. So if he's preterm, if the amniotic fluid is not clear, and if there is risk factors, and we cannot care the placenta. Okay, so what are the care? What are the routine care? Remember, the first step of resuscitation, we provide warm to maintain normal temperature, we position the airway, we clear the secretion if needed, we dry, we stimulate. So the first is we warm the baby. So how we warm the baby? Okay, so we swaddle the baby after drying. That means we wrap the baby with a towel. We can put the baby on the skin of his mother or her mother, and then put the cloth of the mother over the baby. We can use not urethane, wrong, the polyethylene bags or plastic bag or wrap. We use it for babies less than 1,500 grams. We use warm pads. So if you see the warm pads, it's the same that used by the army when they want to heat. So it's a chemical. Once you click it, it's a phase change variable. Once you break it, it become warm. So that's warm pads, okay? We can use the radiant warmer, the open bed, the resuscitator, and we always have to use the oxygen in correct way. So what are the patient right regarding oxygen? How we should give oxygen, Razhana or Rejana?
Sorry, if you repeat it.
So how we should give, what are the patient right when receiving oxygen? How we should give oxygen? So it should be, Rejana, it should be humidified, heated, and blended. Humidified, heated, and blended. Why? Because we have no oxygen scavengers. We have no oxygen removal. We cannot remove from our body oxygen radicals. So if we give oxygen more than 21%, the human being will not be able to clear it out. And it accumulates the body, the radicals, the oxygen radicals, and cause inflammation. So it causes inflammation of the brain, inflammation of the heart, inflammation. And if you continue doing that, whether you're like newborn or pediatric or adult, you will die at some point. Okay? Because people think that giving more oxygen is a good idea. So it's very important to remember that we need to blend the oxygen. And what's blending mean? Mixing the oxygen with medical air, because the air will give the flow, because sometimes we just need the flow. And then we give 21%. But if my need, we go 25, we go 30. And once you need oxygen more than 30% for more than 15 minutes, you probably need to upgrade your support. So blended. Heated mean the oxygen should be the same of the body temperature, and humidified with water. Okay, so that's what we call it, warming the baby. Second, position the baby. Okay, so it's very important to remember to put the baby flat on his or her back and under a radiant warmer. Okay, the position should be important, not hyperflex, not hyperextend. So it should be a sniffing position where the tip of the nose and the tip of the chin on the same level. So if the tip of the nose higher than the chin, then probably you are flexed. And if the tip of the chin higher than the tip of the nose, then probably you are hyperextend. So it's very important to put the baby in a sniffing position where the tip of the nose and the tip of the chin are on the same horizontal level. And that's when you align the upper airway, and that's when you open the airway. Okay, is that clear? Clear? Yeah.
Clear.
So remember, sometimes you need to use shoulder roll or even head roll to do that. If you need that, then you can do. So in an initial step of resuscitation is we provide warm, as we did in the last slide. We position the baby. Third, we clear the secretion. So clearing the secretion is only when we need respiratory support. If the baby does not need support, you don't need to clean the mouth. It's very important to remember. This is a good nutrition for the baby. Don't take it from him. Even if there is blood, don't take it. Okay? And we only suction when we put the baby in a correct position. We do not suction and the position is incorrect. We always suction the mouth before the nose, and we use the bulb syringe. Rarely we use mechanical suction device. And we do not suction to the back of the mouth or the stomach or esophagus for many reasons. It causes vagal stimulation and brady. It can cause trauma. It can take important nutrition from the baby, and you waste time. So you can see how many problems when you suction. Do not suction. You don't need to suction. Okay? And so we warm, we position, we provide suction. Now we dry the baby. So how we do that? We bring 3 sheets warmed and we put one over another. So we use the first one to dry. Then we carry the baby out. We take it out and throw it. We put the baby back. We dry. We raise the baby, take it out, and then the last one will cover the baby. Sometimes you need 3, sometimes you need 4. Is drying clear? How we dry the baby? And we stimulate. Now this is the big problem. First, remember, stimulation should be gentle. So for example, if you have a muscular guy, you hit that muscular guy by strong. But if you have weak person, you don't hit a weak person strong. So don't stimulate strong for a baby who's not breathing. Okay, so first you need to be gentle. Second, you need only to rub the bag from up down, not from side to side. Up and down, and only wrapping. You can, يعني wrapping تمسح, or you can stroke the sole, so as if you are clapping on the sole. Okay, or you can flick the sole by one finger. Okay, never ever carry the baby from the leg. Always support the head. Always the head above the body. So remember, never carry the baby from the leg. Always support the head. Always the head above the body. Okay? Don't allow the obstetrician to carry the baby from leg. There is no such practice. And it can cause permanent backache for all the human being life. We do not. So one time there was a lady obstetrician was carrying the baby from the leg. So I said, why are you carrying the baby from the leg? It's harm. And she told me, what's your evidence? The evidence is easy. Let me carry you from your leg and see what will happen to you. That's your evidence. If you want to see the evidence, let me carry you from your leg and see the evidence by your eyes. Okay? So please don't carry the baby from the leg. Okay? Do you guys know who's this? Anybody know who's this person? Anybody know this picture? The person in the picture?
No, I don't know.
This is the anesthetist, respected Virginia Abgar, who discovered it's an adult anesthesia. She died 3 years ago, and she discovered the Abgar score. So this is Dr. Virginia Abgar, okay? And they named the Abgar score on her name. And you can see how she's carrying the baby, okay? And that's 1954, okay? So this is wrong, okay? Never carry the baby from leg. Never squeeze the chest. Never rub on the chest. Never rub the abdomen. Never hit the baby. And the baby does not need to cry. These are not Indian movie or Egyptian movie. You don't need to cry the baby. The baby does not need to cry. I don't know from where this comes, that the baby should cry. What happened in Indian movies and Egyptian movies is incorrect. Okay, you don't need water when the baby delivers. You don't need the baby to cry. Okay, as far as you don't need the baby to breathe. As far as the heart rate is above 100, that means the baby is breathing. You don't need to see the baby breathing as far as the heart rate above 100. Is that clear?
It's clear there. Just there is a question that sometimes there's an idea that if the baby not cry, it will be a syndrome. It will be a disease.
No. If the baby is not to cry, check the heart rate. If the heart rate above 100, then there is no problem. Because once the baby starts to desaturate or not breathing, the first thing will drop is the heart rate. So if the baby is not crying, just check the heart rate. That's all what you need to do. Okay. So again, 4 questions. Yes, we do routine care. No, we do the same. We do warming, position, cream. Okay. But we do stimulation. Okay. Now, if the baby responds to stimulation, then we go monitoring care, which means we do routine care plus vital sign check every 2 to 4 hours, and we might need to do sugar, gas, and sepsis workup. Okay? So that is the first block. 4 questions, identification, and then we did action, which is warming, positioning, clearing secretion, drying, and stimulation. So that's the first 30-second block. Is that clear? Is it clear?
Clear
Do you have any question? So if the baby, well, now we will go to the second step of resuscitation. We'll ask 2 questions here. Only, is the baby apneic or gasping? Is the heart rate less than 100? You don't need to count the heart rate. You just need to say above or below. So that's your evaluation. If the answer is yes, the baby is apneic, or the baby is breathing by gasping or irregular, ineffective breath, we will define it later. The answer is yes, then the baby has an apnea and need PPV. The baby does not need stimulation. The baby needs positive pressure ventilation. Okay? And remember, the resuscitation of a newborn is ventilation, 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 and then anything else. So once the baby is apneic, and then we'll define what's apnea, or gasping, and then we'll define what's gasping, and the heart rate less than 100, I will show you how to check the heart rate. Okay, then we give positive pressure ventilation, and then we check the saturation. And we put the ECG probe to check the cardiorespiratory, to monitor the cardiorespiratory status. Now, if the baby is not apneic and not gasping and the heart rate is above 100, we decide, is the baby labored breathing? That's mean increased work of breathing. And is the baby cyanosed? If the answer is no, then that's the end. The baby responded to the first step of resuscitation, which is warming, positioning, clearing secretion, drying, and stimulation. If the answer is no to both of them, then go to monitoring care. If the answer is yes to first one, then we do positive pressure ventilation, we check saturation, and we did ECG. However, if the baby is not apneic, not gasping, and the heart rate more than 100, but he has breathing difficulty, he has cyanosis, then what we do, we position. Here we might need to clear the airway, and then we give oxygen as needed, and we consider CPAP. So what is apnea then? Because we said the question in the second question or the second step is apnea. So apnea is cessation of breathing more than 20 seconds or cessation of breathing less than 20 seconds with decreased heart rate and or cyanosis. Okay, so do you know what's apnea then? Gasping is occasional breaths. It does not provide effective breathing and there is no gas exchange. Heart rate, you don't need to count the heart rate. You just need to do above 100 or below 100. And we check it only and only by stethoscope, not by palpating the umbilical cord, not by putting the hand on the chest, not by feeling the pulse from the arm, not by putting the finger over the carotid. We count the heart rate by listening to the heart rates to the stethoscope. And then once you listen, you don't need to tell people, you just need to do that. So I will show you a heart rate above 100. So I'm going to listen now to the baby and we'll do that on the table by my hand. What is this heart rate? How much this heart rate, Mustafa? So I'm listening and I'm knocking on the table. Okay, I'm not talking. Do you hear it, Mustafa?
No.
What is the heart rate here? What do you think? Do you want me to repeat to you?
It is tachycardia.
It's above 100. You don't need to say any tachycardia. It's above 100. Correct? Because at second step, you don't need to count. You just say above 100 or below 100. So I'm going to repeat to you now. Listen, Mustafa.
نعم عمي.
Because I'm listening and I'm knocking on the table, the sound I'm listening. So what's this heart rate? Mustafa.
نعم عمي يسمع.
What is it? What is this heart rate? What do you think? Mustafa.
عفوا عمي والله يعني بالضبط ما افتهم يعني اذا
بدأ تفتهم علي. I am listening to the baby by stethoscope. And the sound that I'm listening to the heart, I'm converting it by knocking on the table. Do you hear it?
نعم نعم اسمع. يعني الا اذا انا نريد يعني
الا or below 100.
اذا مالتيبلاي يكون above 100.
You don't need to multiply. You just need to tell me by listening to the sound. Is it above 100 or below 100? Listen now.
Below 100. Below 100.
Is this above or below 100?
It will be below 100.
This one. Is it above or below 100 now? Okay, let's select another person.
والله يا عمي اعتذر يعني ما اعرف
Payam.
ما ادري يوصل الفكره.
Payam.
Yes.
I'm gonna listen to a baby. I have a baby. I'm resuscitating a baby. I will put the stethoscope on the chest and I will translate. I will change whatever I'm hearing by knocking on the table. The same out hearing, the same heart rate that I'm hearing. I will knock the table and I want you to guess whether this heart rate above or below 100. Now, do you understand?
Yeah, understand.
Okay, so I'm gonna listen now. I'm gonna knock on the table exactly what I'm hearing.
Okay.
So what do you think? Above or below 100?
But sorry, I didn't hear the knocking sound.
Or you're not hearing the knocking sound?
No, I didn't hear.
We're not hearing. The first time when you talk to Mustafa,
Do you
we
do you
don't
hear
hear.
now knocking?
No.
Oh, you don't need it. Okay, I'm gonna do the sound by I'm gonna do the sound by my tongue.
Should be better. Maybe better.
Okay, do you hear it now?
Sorry, no, I didn't hear it.
Dear doctor, the
You
sound
don't hear
is
a
not
sound
clear.
by my tongue?
No.
You don't hear?
I think
No,
if you're knocking your microphone, it will be better.
Do you hear now?
no, not yet.
You don't hear anything?
No. Between
No.
heart rates.
You're not hearing this sound now?
No, sorry.
Top, 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 top. Do you hear now?
Yes, yes.
Okay,
More than
Alhamdulillah, then. Okay, top, 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 as if I'm knocking on the table.
more than
What's
100
the
it
heart rate
means.
now?
I think.
Yes. Now listen to the sound again. Top, top,
Below
top.
100.
Yes. So that's what I will do. I will knock on the table in the sound that I hear from the baby. And then you guess, everybody is with me, will know what is the heart rate. Now, do you understand? So you listen on the chest and you knock on the table. Now, do you understand?
Yes, it's clear.
Yes.
Yeah, I get
Yeah.
it.
Yeah. So our sometime we need to record it. So what we do, we count it over 6 seconds and we multiply it by 10, or we count it over 10 seconds and multiply it by 6 to get it over 100. And you don't need exact number. We just need above or below 100. So if a baby apnea, gasping, or below 100, then you provide PPV, you check the saturation, and you put a cardiorespiratory monitor. Okay? But also we said if the baby is above 100, not apneic, not gasping, we check what is cyanosis. And what is cyanosis? Is blue discoloration of skin and sclera. And the reason of cyanosis is when we have hemoglobin, and hemoglobin is carrying oxygen. So when the hemoglobin is carrying CO2, or we call it carboxyhemoglobin, more than 5 grams, the cyanosis will appear. The cyanosis can be central and can be peripheral. So when we say cyanosis, we are talking about the central cyanosis in the eyes, in the skin, in the mouth. So this is cyanosis. Do you guys know what is cyanosis?
Yes, we
Do
know.
you understand? Okay. Or we have labored breathing. Labored breathing means use difficulty in breathing, retraction. Okay? Use of accessory muscle. Okay. So we said that when the baby is not in labored breathing, not gasping, not apneic, and heart rate above 100, we will say if the baby labored or not. If the baby labored or cyanosis, we provide oxygen. So how we provide oxygen? We either simple mask or nasal cannula or flow inflation bag or cup-like hand or air oxygen blender. So this is simple mask. So a mask that is transparent and have two knobs. And some of the mask we put a flow here. When you see this in a mask, it's called Venturi, because each color has certain flow. So we have multiple colors, and we can have 2-liter flow, 3-liter flow, 4-liter flow, and so on. So if you see this, it's called Venturi. If you don't see it, connect directly, we call it simple mask. Okay, we can have nasal cannula. A nasal cannula, the two legs are short. When they are very prolonged, they call it nasal prong. So nasal cannula, nasal prong. Okay, we can have flow inflation bag, and we've talked about it in child, acute care of child. And usually there is bag, and there is safety valve here, and sometimes there is no safety valve, and sometimes there is only opening that you can hold it by your hand. Okay, you'll see that you provide flow, and there is gauge to measure the pressure you're giving, and then connect it through this piece. And there is pop-off safety valve here. Do you see my mouse? Guys, do you see my mouse moving?
Yeah, we see.
Yeah, so this is the safety valve, and this is the mask. Okay, we can use cupboard, and we can use the corrugate tube. And we need sometime air oxygen blender. So a black color, air and oxygen. Okay, so this is where you dial the oxygen, and here where you dial the flow, and it's blended and it goes to the baby as one. So we determine how much flow we're giving and how much oxygen. So we can give room air, but we can give like 10 liter per minute flow. But while if you're using only oxygen, the percentage of oxygen determined by the flow. So you cannot give high flow with low oxygen. That's the benefit of air oxygen blender. Okay, we can provide CPAP, and we have two different types of CPAP. We have constant flow CPAP, and we have variable flow CPAP. But the CPAP will give you continuous pressure through both respiratory cycle. Through PEEP and PIP, we can use it. And there are many types of CPAP, of course. CPAP is continuous positive airway pressure. We can provide PPV, or called positive pressure ventilation. We can use flow inflation bag. We can use self-inflation bag. We can use TPs with the new puff. I will show you, inshallah, when the new puff, when we have a meeting. And when you do PPV, it should be 40 to 60 events squeeze per minute. Should not be more, should not be less. Clear? The PPV? We can provide PPV through flow inflation bag. We can provide PPV through self-inflation bag. And we can use the TPs, which is a machine that we can take it with us everywhere we go. Okay, so it gives us the PEEP and PIP. So we determine that, and we just put it on the baby, and it will deliver the PPV. Okay, now how we use the PPV to get 40 to 60, we should coordinate. So we do like this. Squeeze, and 2, 3, squeeze, 2, 3, squeeze, or squeeze, 2, 3, squeeze, 2, 3, squeeze, 2, 3, squeeze, 2, 3, and so on. Or you can say 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe. So that's how you coordinate your breathing to get 40 to 60. And we always start with room air. Okay, in premature baby, we might start with 30%. And if we need, we can increase it. Now, do you understand how to do PPV? Guys, please talk to me.
No, I didn't understand.
Okay, so when you do, you need to do 40 to 60 squeeze per minute. Okay, is that clear? You need to give 40 to 60 squeeze, 40 to 60 breaths per minute. Okay? To do that, you need to coordinate it. So how we do that? you count with the breathing. So what do you say? Breathe. When you breathe, you squeeze the bag. Breathe. You're talking. You're people listening to you. Exactly what I'm doing right now. So I will say breathe, 2 and 3, and breathe. 2 and 3, and breathe. You understand? I will show you. When we meet, I will show you. Payam, are you talking to us or talking to somebody else? Payam. Okay. Now, do you understand how we do the PPV? And then I will show you in the practice, inshallah, how to do the PP, how to coordinate. Okay. Now, once we do the PPV, we need to check the saturation. And the saturation, we use a pulse oximetry. As you can see here, we are using Massimo Radical 7 machine. Okay, and it should be always on the right upper hand to be preductal, I mean before the duct. Okay, and the saturation should be between more than 88 to 91 in the premature baby and more than 94 in a term baby. Is that clear, guys? Because if you don't, that you don't understand, I don't know what to do. So please, if you don't understand, just tell me. Huh? Okay, then you need to connect the EEG, the ECG, sorry, which is the 3 probes. So when we provide PPV, you need oxygen saturation, right upper hand, and then you need the ECG on the cardiorespiratory monitor. So again, this is the algorithm. Question, birth, for question, yes, routine care, no, routine care with stimulation. Questions, apnea, gasping, heart rate below 100. Yes, PPV, saturation monitor, ECG. No, ask the question again. Labored, breathing, or cyanose? If yes, give oxygen, consider CPAP. If the baby responded here, and yes, and there is no, you go back to monitoring care. So remember here, routine care, at this step, monitoring care, and if you pass this step, it's intensive care. Okay? So once we finish the first 30 seconds and the second 30 seconds, we reach here. Now, after that, we don't need to say apnea or not. We just check the heart rate on the third step. So first 30 seconds, second 30 seconds. In the third 30 seconds, we don't need to say gasping like the first one and second one. We just need the heart rate. So if the heart rate above 100, if the answer is yes, or if the heart rate below 100, if the answer is no, then you go intensive care here because you pass the second step. If the answer is yes, the heart rate below 100, then you need to look at your chest movement. If the baby, you are doing hand ventilation and the chest is not moving, consider intubation. And then we'll go with the step of resuscitation. Now, the further step of resuscitation is not a nursing concern, so I'm going to stop here. Now, when we look at the saturation will not reach to the adult level in the first few minutes. It will reach within 10 minutes. So this is the target. Remember that. This is target preductal right upper hand saturation. So I'm going to pass these because this is not the job of nurses. Okay. However, in the third question, you remember the first question was, the first step, the question was 4. Is the baby term? Is the amniotic fluid clear? Is there is a risk factor? Is there is a care for the plan? Now, if yes or no, we go routine care. If no, we go routine care plus stimulation. And then we assess 2 questions, gasping or apnea, heart rate above or below 100. If yes, then we do positive pressure ventilation and check the saturation and put ECG. If the answer is no, we say is labored breathing or cyanosis. If the answer is yes, we give oxygen and consider CPAP. If the answer is no, we go to monitoring care. If the heart rate below 100 and we give PPV, then we have to go after our PPV, which is 30 seconds, to see if the heart rate above or below 100. Okay? If we fail to put ETT, we might use the LMA, laryngeal mask airway. LMA, laryngeal mask airway. Okay? And then we go to the, once we finish the resuscitation, we do debriefing. So we brief before, we debrief after. Okay? And then I will pass the steps of resuscitation. We might need to do chest compression, chest massage, CPR. Okay, I will practice CPR later on, not today, because also not nursing concern. Remember, when we do chest compression, instead of we say 2 and 3, we say squeeze. So we say breathe, squeeze hard, breathe, squeeze hard, squeeze. Okay, so once I say 2 and 3, the doctor or the other person will squeeze the chest to do the massage or to do the chest compression or to do the CPR. So breathe, push, push, breathe, push, push, breathe, push, push. But when he or she push, I say 2 and 3. So breathe, 2 and 3, push, 2, 3, push, or squeeze, 2, 3, squeeze, 2, 3, or breathe, 2, 3. So when the person doing the PPV and say breathe and then 2, 3, with 2, 3, the other person will massage the chest. Now this is the self-inflation bag, and see the hold. The C and the E is very important. When you push the C, you push it on the E, not on the baby. Okay, so you can see, breathe, release, release, okay, and so on. So remember that you say breathe, 2, 3, and when you say 2 and 3, you squeeze the chest, and then you say breathe, 2 and 3, breathe, 2 and 3, and so on. In this situation, you will get around 120 events. 2 of the 3 events will be chest compression, and 1 of the 3 events will be breathing. Okay. We might need medication. So remember, the doses are when the heart rate below 60 at any point, and you might need to give epinephrine through an IV line, and if you don't have, we through ETT. Okay, and so remember, we have 3 types of care. We have well baby care, we have monitoring care if the baby needs stimulation, and we have intensive care if the baby needs more than the first 2 steps of resuscitation. Once in the intensive care, we do post-resuscitation care. We transfer the baby to an ICU. We do respiratory support, cardiovascular support, and initial course of resuscitation. Okay, so what are the care that we provide with babies post-resuscitation? We treat apnea. We treat difficult breathing. If the heart rate less than 600, we might start fluid. We might give CPAP, we might give caffeine, we insert line, we give surfactant, and so on. Causes of failure, many, I will pass it. Discontinuous resuscitation, if no response after 20 minutes, then we stop resuscitation. Withholding resuscitation, we don't do resuscitate for babies less than 23 weeks. We should discuss it with parent. And when there is multiple malformation, and we do what we call it comfort care. Comfort care mean we don't resuscitate, but we don't cause pain. Okay. Now the not resuscitate depend on the hospital, on the country, and so on. And I am done. So guys, what do you think about today's session? Difficult?
It was a very important session for us, but there are very new things to us too.
We'll practice. So I know what I want from you guys. Please work with what's his name, Ibrahim Mustafa, because he's preparing to us the court, the meeting room. So please work with him, your timing and your date. So I come when he's making the place ready for you to come. So I start to show you some few things that we're studying in the last week, because I need now to do practice. So please work with him on a time and a date, and we can repeat that. If the time and date not suit everybody, we can do 2 sessions. So please work with him. Either you select one person to communicate with him, or all of you talk to him. Do you know him?
No, we don't
Ibrahim?
have contact with him.
Oh, he's inside the group.
But he mentioned a day for the meeting, but we don't meet each other.
Yeah, so we just need to tell him, because he also texts you inside the group to select the date and time.
Yeah, he already did it.
Yeah, so just communicate with Ibrahim. Let me see if he's inside the group, because I think he's inside the group. Let's go to the nurses. Nursing group. Maryam, Sundus, Rizhana, Howard, Sundus, Maryam. Muhammad Faisal Ibrahim. See the message? He told you, Salaam alaikum. Which day do you prefer of having practical session? Nobody answered him. He did that.
I said he already did it.
Yeah, you said already did it, but you need to work with him. The date and time, you need to inform him. Which date and which time you selected.
So sorry, doctor. Do you know the problem is many of us have a formal duty, whether private or be public, within the government. So it makes the big problem. And as you said, if you make 2 sessions, it will be better for us.
Yeah, just work with him.
Either,
Just work with him on your timing and date, and I will be there. Just work with Muhammad Faisal Ibrahim. Just work with him. He's inside the group, and he's the person who is responsible to prepare that. Just work with him, please, about whatever date and time you want, and I will be there. And we can do it more than one session. Okay?
Okay, inshallah.
Can I depend on you?
Inshallah.
Okay.
inshallah,
Before
we make it
guys,
according to your
yeah,
available time. As you said,
I
maybe
am always available. No worry.
Yeah.
Even during the clinic, I will cancel the clinic. I just want you to come. I don't want excuses. For me, I will come at any time. Okay,
appreciate your
I will
effort.
stop working. Yeah, I will stop working. So I want to show you something before you go.
Appreciate your effort.
I will show you something. Do you see my screen?
Yes, I do.
That's clear. Yeah.
Yeah. So there is what we call a checklist for nurses. Okay, so you can write your name and you're gonna sign it, and there is score. You can see 0, no experience; 1, minimum experience; 2, comfortable performing with resources available, competent to perform independent and safely; and 4, when you can teach other. Okay, so there are items and procedure, and then you need to score yourself. So it's already checkbox. So if you stand on it and you click, you can see, you can click whatever you like. And if you click again, it will disappear. Okay, so it's in words. You can see, for example, I can communicate and okay. So I will send it to you, and then you can see, can you do Glasgow Coma Scale? You said no. Okay, I will teach you then. Okay, you said no, I am, you can see the score here. Minimal experience. So whatever you write, then I will look and I will try to teach you whichever missing from you. For example, do you know ROP protocol? No, I don't. Then I will provide you one. You said, no, I have very experience and I can teach others. Okay, so I will ask you to teach others. Okay, and so on. Okay, so noise control. What is the noise needed in an ICU, for example? Do you know cluster of care? Do you know, for example, medication for sedation? Do you know? Do you know seizure? Do you know medication for seizure? Do you know what's ABD, apnea, bradycardia, and desaturation? Okay. Do you know how to give caffeine and so on? Okay. So you just need to click whichever you feel is suits you. Okay. So you can see we have respirology also. You can see everything in respirology. We have the GI and GU checklist. You can see all the medication in an ICU and PICU, whether you have experience with them. You can see all. You can line skills is there, resuscitation skills and certificate, pulmonary skills. You can see other competencies all there. And then your experience, an ICU, PICU by years, and you can tick here and then put year and month. Okay. So I will distribute it to you and each one fill with you and then send it to me. And then I can put a program for each one of you of the training, because after I teach you the principles, okay, not, you don't need everything. Like you need only those that you're missing. Is that clear for the checklist?
It is clear. Just there, doctor, about deadline. If there is any deadline